Good evening, everyone. My name's Andrew Coe. I'm the chair and moderator of this session. In a minute, we're actually going to show a couple of videos. And this is from the Lustgarten Foundation, which helped to organize this event. They're actually a major organization that helps to fund some of the most cutting-edge research in pancreatic cancer that's going on nationwide. And they have a program called Let's Win, which provides a patient perspective, a sort of patient-oriented perspective that's I'd like you all to take a look at, because I think it kind of reminds us of why we're all here, and it helps us to keep this a very, I'll say, patient-centric sort of focused meeting.
When I was first diagnosed with pancreatic cancer, I thought my life was over.
When my doctor said, "Lori, I am so sorry you have pancreatic cancer," I said, "I do not. That's a death sentence. You have the wrong file."
My first thought upon being diagnosed was that this was probably a death sentence.
I was told that I may only have 3 to 6 months to live.
These cancer hospitals, they felt so sorry for me and they were going to help me die. But that's all they could offer was, "We're going to help you die."
I'm Cindy Gavin, founding executive director of Let's Win. Let's Win is an online web-based platform where we connect doctors, patients, and researchers with the latest science-driven treatment options for pancreatic cancer.
Pancreatic cancer is one of the hardest diseases to treat, and I tell my patients every day that there is reason to have hope.
When people go to the internet, when they're newly diagnosed, all they typically see is terrible statistics, and our goal is to change that.
You want to hold up cue cards?
In 2018, Let's Win is launching a survivor video series. Each month, you will meet a long-term survivor of pancreatic cancer. Their stories provide so much hope to someone that's newly diagnosed.
I didn't know of any survivors. I hadn't heard of any survivors.
I was reading too much negative.
I wasn't going to let statistics scare me. We were going to fight it.
Maybe I don't have to die.
I attended a celebration of life. We had patients in the room that have survived pancreatic cancer for many, many years.
The doctor gave me about 6 months to live, but then my children said, "We have to find someone else." The day before Christmas, he called me and said, "No more cancer."
We are working day in and day out to discover new and better therapies for your disease. I am an oncologist specializing in pancreatic cancer. I want you to know that pancreatic cancer is treatable.
I'm a 3-year survivor of pancreatic cancer.
I'm a 7-year survivor of pancreatic cancer.
I was diagnosed when my son was 3 months old, and today my son is 8.5 years old.
11-year pancreatic cancer survivor.
I'm an 11-year survivor.
I'm an 11-year survivor.
I'm a 15-year survivor.
4-year survivor of pancreatic cancer, which around here makes me an amateur.
I'm a 15-year pancreatic cancer survivor.
I'm a 17-year pancreatic cancer survivor.
I was diagnosed with stage 4 pancreatic cancer 19 and a half years ago. This spring will be 20 years.
Our goal is that when people turn to the internet, instead of seeing statistics, they see life, they see hope, they see survivors.
Don't think of yourself as dying from pancreatic cancer. Think of yourself as living.
I know it sounds difficult to be happy, but in the moment, we really can be happy. We don't have to think about what's going to happen, because none of us know what's going to happen tomorrow.
This is my permission slip to live the life that I authentically want to live.
Life is all about falling down, but living is getting back up, and that's what you can do with cancer.
I'm a professor of medicine at the University of California, San Francisco, so welcome to San Francisco, my home turf. And tonight's educational symposium is titled "The Quest to Win Through Science in Pancreatic Cancer," from sequencing current options to testing novel approaches. I appreciate your choosing to come here this evening. You obviously have a range of options, and clearly those of you who are here are doing so because of your professional or maybe personal interest in pancreatic cancer. Joining me for this peer review live symposium, I'm really pleased to have a couple of esteemed colleagues, Dr. Andrew Hendafar from Cedars-Sinai Medical Center in Los Angeles, and Dr. George Kim from the University of Florida Health System in Jacksonville, Florida.
Access the entire activity and complete the post-test at www.peerview.com/NMJ. Downloadable slides and practice aids are also available.
Okay, so why don't we get started? And these were a few questions that I think we developed that I think are going to be ripe for discussion and would just be interesting to see what your particular practice patterns are for scenarios that we thought were fairly common. So the first question had to do with a woman, let's call her Susan, 64 years old, and she actually was originally diagnosed with localized pancreas cancer, underwent Whipple resection, postoperatively took some time to recover with residual fatigue and some nutritional challenges, but ultimately recovered to be able to discuss the role of adjuvant therapy. So she received adjuvant treatment for 6 months with a combination of gemcitabine plus capecitabine, did reasonably well, some oral stomatitis and cytopenia, so had to be dose reduced along the way. But unfortunately, 3 months after completing her adjuvant therapy, she demonstrated metastatic disease to the liver and lungs. ECOG performance status is okay, estimated at a 1. So we posed this question, well, what would you recommend for this patient who recurred at 3 months after completing adjuvant chemotherapy? George, who will be our first speaker, is going to talk a little bit about this. And the reason we kind of developed this question in part is because this is an individual who was exposed to both gemcitabine and a fluoropyrimidine, and so I think it raises some interesting questions about what to do next. Now, if we take the same patient who underwent resection, 6 months of adjuvant chemotherapy, but now instead of just 3 months later, it's more than a year later, where on surveillance imaging, she has metastatic disease. Okay? Following perhaps your practice patterns, she's treated with the combination of gemcitabine plus Nab-Paclitaxel, does well for a few months, but then shows evidence of further progression. So we'll call this second-line therapy. I'll say second-line therapy for metastatic disease. This would really represent in some ways her third exposure to chemotherapy, the first having been given in the adjuvant setting more than a year ago. And now finally, in getting a little bit in terms of not just where we're at present, but where we may be going, and this will dovetail nicely into Dr. Hendafar's talk in the second portion of this session in terms of some molecularly guided approaches to treatment. Let's say you're seeing a new patient with metastatic pancreas cancer, and most folks thought that's really a number of different options here. BRCA1 and 2 mutations, ALK rearrangements, or high hyaluronic acid may be useful features in determining his eligibility for trials using targeted therapies in pancreatic cancer. And so I think Dr. Hendafar will shed some light on these. And just to set the stage for you agenda-wise, so we'll start by having Dr. George Kim give us his perspective and the data on the current landscape for pancreatic cancer. And we'll focus primarily on the advanced metastatic setting, looking at questions of sequencing, selections of therapy, and how we go about deciding that. What's a little different than perhaps other talks you've come to is that we'll then have an interlude, kind of going back to these patient vignettes from Lustgarten's Let's Win program. And we'll look at a few patient stories with a few audience response questions that I think these true patient stories may highlight. And then finally, for the latter portion of this evening, Dr. Hendafar is going to be talking about what's on the horizon, kind of what we've got going on in the clinical trial arena, now that we're doing more molecular profiling of patients, how that information might inform us. So I think that will hopefully give us a renewed sense of vigor and optimism in treating this disease. So with that, I will turn it over to my friend and colleague, Dr. Kim, who's going to give us a closer look at advances in cytotoxic backbones in pancreatic cancer. George?
Thank you. Thank you. And good evening. And I also want to express gratitude to the Les Garten and Let's Win. Early on in my career, I went to one of their symposiums in Boston, and that's really one of the first inspirations for studying pancreatic cancer for me early in my career. I also want to thank Dr. Ko for having me participate, and also PVI and peer review, so thank you very much. So this is the Master Class 1. So I am the professor or the teacher, and you are the students. And we're going to teach you guys how to treat pancreatic cancer. Pancreatic cancer is the 4th leading cause of cancer-related death in the United States. Roughly 55,000 new cases, 44,000 deaths, okay? It is number 4 in both men and women. Survival is poor. Overall survival is about 8%. And why is that? Because over here you see that most patients are diagnosed with metastatic disease or distant disease or regional disease, and these patients ultimately succumb. So we've got to do a much better job of finding more and more patients that can have potentially resectable, curable surgery. Median age of diagnosis is roughly 70 years, sorry. And then the majority of patients, again, present with advanced disease. So this is one of the reasons that pancreatic cancer is so difficult to treat and why these statistics are poor. And then this is a rather scary statistic. It's projected that by 2030, pancreatic cancer will become the 2nd leading cause of cancer-related death. So we really have got to get the work done now so that we can change these numbers, but a 71% increase from 2010. So this is roughly 12 years from now that we're going to see pancreatic cancer become the number 2 cause of cancer-related death. So again, a lot of work has to be done. Okay, so screening, what are the risk factors? We really have no screening tests, and let's be honest, the progress in pancreatic cancer is going to be made with screening tools. Somehow we've got to figure out a way to identify patients so that they can go on to potentially curative surgery. But we do know some of the risk factors. So advancing age, gender, ethnicity, especially Ashkenazi Jewish ancestry. That's related to the BRCA2s, Lynch syndrome, so that's the HNPCC, or the microsatellite high, folks, and we're going to talk about that tonight. Family history does raise your risk, especially if it's in first-degree relatives. Diabetes, chronic pancreatitis, obesity, and tobacco use are all risk factors. Down here, alcohol is a risk factor, probably related to chronic pancreatitis, and then caffeine. Now, that was studied long ago, and caffeine is no longer a risk factor, thank goodness, because I drink a lot of coffee. So, not a risk factor. All right, so those are the risk factors, and again, we just have to be aware of them. If you've heard me speak before, you know I'm going to say that pancreatic cancer patients are unlike your other cancer patients. They're unlike your colon cancer patients. They're unlike your breast cancer patients. They have significant disease-related complications and symptoms, okay? What does that mean? And really, one of the take-home messages tonight is that the care of pancreatic cancer patients is a team effort, okay? The advanced practitioners, the nurse practitioners, the PAs, the chemo nurses, the nurses really have to keep an eye and help the oncologist treat these patients, okay? So very important to maintain their performance status. So what does that involve? Keeping their pain under control, oral agents, topical agents, long-acting, celiac neurolysis, all of these efforts to keep the pain under control. Pancreas insufficiency. Many patients have difficulty absorbing the food, the nutrients that they take in, so we have to do a good job, make sure that pancreas enzyme replacement may or may not be indicated in folks, okay? Biliary obstruction and intestinal obstruction also can be seen. This leads to cachexia, depression, malignant ascites, and also an increased risk of blood clots. So again, very important to manage and optimize the performance status of these patients. All right. This is the other reason on a biologic level why pancreatic cancer is so difficult to treat. What this shows is this pink whirlish material. You think it's nice and soft, but it's not. It's stroma, it's desmoplasia. It's a protective barrier around the cancer cells shown here, the adenocarcinoma cells, okay? So we really have to break through this stroma. And when some of our therapies do that, but we have to break through the stroma to access the cancer cells and so that we can kill them, okay? Very important. All right, so this is the timeline of available treatments for pancreatic cancer in 2018. So for many, many years, we had gemcitabine. Then came along Gemcitabine, and then FOLFIRINOX, Nab-Paclitaxel, Gemcitabine, and then nanoparticle liposomal Irinotecan, okay? So these are the treatments that we have available. I'm just gonna highlight for you folks, what's not on this slide is Irinotecan by itself, okay? It's really nanoparticle liposomal Irinotecan, okay? All right, so let's go through the two standard treatments that are available for metastatic pancreatic cancer patients in the front line. So the first regimen is the FOLFIRINOX regimen, and you guys all know about this. This is a French trial. 342 patients were treated. They did a little bit of selection in terms of performance status, only 0 and 1s, and they limited the age of the patients to no one over the age of 75. So the other highlight here is that this study was only done in France, and it was done at academic centers, and they did a really good job of understanding the toxicities and working it up from a phase 1 to a phase 2 into a phase 3. So they had a lot of practice, if you will. The trial was FOLFIRINOX, 171 patients versus gemcitabine, and these are the doses. Okay, these are standard doses of all the GI cancer drugs, oxaliplatin, irinotecan, bolus, 5-FU. What they showed in terms of the primary endpoint is here, an 11.1 month median survival, okay, versus a 6.8 month median survival with the control arm. Hazard ratio of 0.57, log rank p-value, statistically significant, okay? So, very important. This was an improvement in survival, an important achievement in the treatment of metastatic pancreatic cancer. Next slide shows PFS. PFS also was improved, as you would expect. Hazard ratio of 0.47. But the good comes with some side effects. So what they encountered was 46% grade 3, grade 4 neutropenia. 43% of patients needed growth factor. Febrile neutropenia was right around 5.4%. Thrombocytopenia also was observed. Other side effects of importance, vomiting, roughly 14%, diarrhea, 13%, and sensory neuropathy, right around 9%. And these are toxicities that we've seen with these regimens in the past, and they're in the same magnitude of levels here, so not that unexpected. Okay, so what we've done, so this was again the French trial, we brought it to the United States. And so what a lot of people have done is, well, let's get rid of the bolus 5-FU, or let's at least reduce it. Let's change the irinotecan dose. Let's add growth factors and make reductions of other components. And there actually is data on US soil with this regimen. This is a study from Yale showing a survival of about 10.2 months. At this meeting is a very interesting presentation from our colleagues at SWOG. And the importance of that study is that they used FOLFIRINOX as a control arm with another experimental drug. And in their survival, their median survival was roughly 15.1 months. This was the first time that FOLFIRINOX was studied on American soil in a trial. And I think that's provocative, intriguing, and very interesting. I talked to Dr. Ramanathan, the lead investigator. Roughly 60% of patients were treated at academic centers, 40% were treated in the community. They did not report grade 3, grade 4 neutropenia. So it's pretty interesting data. But this is what we've done with FOLFIRINOX in the United States. Okay. All right. Well, what's the other standard treatment? The other standard treatment is gemcitabine combined with Nab-Paclitaxel. And that's shown here in the MPACT trial. The MPACT trial was a phase 3 randomized study, again, treatment-naive patients. They tried to confuse us with Karnofsky performance status, greater than or equal to 70. Basically, that means they were more inclusive in the patients that were enrolled, both ECOG 0, 1, and 2, okay? And the primary endpoint here was overall survival. It's important to note this was a global trial. So this wasn't just a French trial, it was a global trial. The majority of the patients were treated in the United States. The majority of the patients were treated in the community. So very much real life, real world experiences. The design of the trial was Nab-Paclitaxel combined with Gemcitabine versus Gemcitabine. Here are the doses, 125 milligram per meter squared and 1,000 milligram per meter squared of the Gemcitabine. The primary endpoint was overall survival, and you see here very clearly the combination of Nab-Paclitaxel and Gemcitabine led to a superior outcome when compared to Gemcitabine. And here the median is 8.5 versus 6.7, hazard ratio 0.72, and again, a statistically significant p-value, okay? Other secondary endpoints, PFS, 5.5 versus 3.7, again, hazard ratio 0.69, a p-value. So that comes also at the cost of side effects, but not as high as what we see with FOLFIRINOX, neutropenia now 38%, thrombocytopenia 13%, use of growth factors lower, roughly 26%, okay? All right, what else did we see? Well, this is a taxane, so we saw peripheral neuropathy at a grade 3 level of roughly 17%. Now, this is an important point. What you see with Abraxane is the neuropathy reaching these levels at about 5 months, 6 months, right around the time that we see neuropathy with Oxaliplatin, which is a component in the FOLFIRINOX regimen. But if you hold the Abraxane for roughly 30 days, roughly 44% of patients can restart the Abraxane, meaning the neuropathy improves, all right? So it's very important, and that's different from what we see with oxaliplatin neuropathy. Oxaliplatin neuropathy gets worse, so there are opportunities to get around and manage, again, this neuropathy. Okay. So we're not supposed to compare studies. That's a no-no. So let's go ahead and do that. This is a comparison between the Accord trial and the MPACT trial, FOLFIRINOX versus Nab-Paclitaxel. So it's important to acknowledge that the study was done in France, again, academic centers, 342 patients. Nab-Paclitaxel was studied in a larger number of patients, global, most of the patients in the US. Eligibility was restricted by age and also performance status. And this was not restricted by age and more inclusive. Survival was 11.1 months versus 8.5. If you try to compare some of the ECOG 0 patients from the MPACT trial, survival actually goes all the way up to 12.6, so somewhat comparable. 1-year survival. Response rates, everybody says the FOLFIRINOX response rate is higher at 32% versus 23%. You have to remember that there are different methodologies in measuring the response, and if you let the investigators assess their own scans, as they did in the French trial, the response rate with Nab-Paclitaxel goes up to 29%, okay? So very important. In terms of grade 3, grade 4 toxicity, certainly fatigue, neutropenia, and neuropathy. And again, the neuropathy with the Abraxane is reversible. With the neuropathy with the oxaliplatin is more difficult to reverse, and it is cumulative. Poor performance status patients were included in the Nab-Paclitaxel group. Quality of life was included in the FOLFIRINOX trial. They did some post-hoc analyses in the MPACT trial. And then cost effectiveness, this is still being debated. The issue with FOLFIRINOX is the inclusion or the need to include Neulasta, which certainly raises the cost of the regimen, and also the cost-effective analyses have not included whether you put the patient in the hospital. Certainly that affects cost, and also, as I started off, if you really push a pancreas cancer patient into the hospital with a lot of toxicities, especially in older patients, their ability to rebound and come back and get additional treatment can be difficult. So all of these are the considerations in the two treatments that are available in 2018 for metastatic pancreatic cancer. Okay, this next slide then highlights what you're supposed to do. If you are sitting in your clinic and you have a patient with a good performance status, you're supposed to put them on an experimental study, a clinical trial, and we're going to talk about that tonight, okay? But the preferred regimens are FOLFIRINOX in the good performance status patients or Gemcitabine Nab-Paclitaxel in the good performance status patients, but also the poor performance status patients. Please don't use Gemcitabine anymore. Gemcitabine can be used on occasion. In your poor performance status patients, Gemcitabine, Capecitabine, continuous infusion 5-FU, and I'll also use Gem/Abraxane, probably at reduced doses in that group, okay? All right, so let's go on to second line, okay? Now, second line therapies, as you saw in the case that was considered, what is category 1? So we're going to separate the two groups in either patients get Gemcitabine-based therapy or 5-FU-based therapy in the front line, okay? So category 1, what is recommended is 5-FU leucovorin combined with Nal-IRI. And we're going to go through what Nal-IRI is. ASCO recommends this in patients with good performance status 0 or 1, okay? So bona fide, Onivide, that's the treatment category 1 in the second line setting in Gem refractory patients. In the 5-FU refractory patients, it gets a little gray here. You can try Gem Nab-Paclitaxel, but again, you run into issues with concomitant toxicities, that being neuropathy and thrombocytopenia, okay? All right, so let's go through what is available in the second line. So for many people, they believe that oxaliplatin is a good second line treatment, especially in the patients that have received Gem-based therapy front line. What's the problem with that? The problem with that is that we have data that contradicts itself. So we have Conco-003, phase 3 study using the OFF regimen. This is not FOLFOX. This is a different regimen. Oxaliplatin is given every 2 weeks, but infusional 5-FU is given weekly for 24 hours. In this trial, they showed that the OFF regimen produces about a 6-month median survival versus the control arm, okay? Now we have to contrast that to the work from Canada. NCI Canada did the Pancreatic trial, phase 3 study comparing now FOLFOX, modified FOLFOX6 versus 5-FU. And what they showed here, surprisingly, was oxaliplatin, the FOLFOX, only resulted in a median survival of 6.1 months, and the 5-FU almost 10 months. So this is why using oxaliplatin in the second line is controversial. Now you're going to say, well, they're Canadians and it's got to be really cold up there, and that's why they couldn't tolerate oxaliplatin. Hope there are not a lot of Canadians in the audience, but that might be one explanation. All right, let's move on. So what is available in the second line? Well, what's available is nanoparticle liposomal irinotecan, Nal-IRI, okay? So let me try to explain. I'm not really a scientist. I may look like one, but I'll try to be scientific here. What you have are irinotecan molecules, 80,000, these little French fries, in a liposome, okay? So they're compartmentalized, and that results in favorable pharmacokinetics. So what happens is 95% of the irinotecan stays in the liposome for up to 1 week, circulates throughout the body, okay? It also allows the irinotecan to get closer to the tumor, 5 times higher levels of SN38, the active metabolite of irinotecan, gets into the tumor compared to regular irinotecan, okay? So again, getting back to breaking down the stroma, getting the drug close to the tumor in the stroma, the pharmacokinetics perhaps helps enable this to occur. It was studied in a phase 2 done by Professor Ko, showing a median survival of 5.2 months. So this is what Nal-IRI is, and this is what the pharmacokinetics are that make it more favorable for use in pancreatic cancer. Let's go through the trial that led to Nal-IRI being approved by the FDA in October of 2015. This is the Nap-IRI-1 trial. This was patients with metastatic pancreatic cancer. They had received prior gemcitabine. These are the stratifications, and we'll talk about the regions and the ethnicity in a minute. This was the original trial design. So this is the control arm. This is the CONCO3 control arm with the infusional 5-FU that I showed you earlier. And this was the Nal-IRI monotherapy, okay? So that was the original trial design. And then they had safety data become available from a colorectal phase 1 trial, combining with Nal-IRI with infusional 5-FU. And so they compared this to the control arm as well. So what you have are two pairwise comparisons to this control arm, monotherapy versus the Nal-IRI regimen, okay? Primary endpoint was overall survival. And looking at patient characteristics, again, this drug was developed in Taiwan, so there are East Asians, roughly 30%. They were both Taiwanese and South Koreans. And then 60% were Caucasian. And that's important when we talk about toxicities and maybe some of the management of neutropenia. In terms of prior therapy, so this is very important, and that's why the question was worded 3 months, 12 months, okay? So who was included on the trial? Remember, you had to be gemcitabine refractory. So you could have actually received gemcitabine in the adjuvant setting, so neoadjuvant, adjuvant, locally advanced disease. You could have received gemcitabine, and then when the patient became metastatic, they were then eligible to be enrolled in the trial. So that's why we were asking that question, roughly 13%. 53%, 56% were true refractory metastatic patients, so meaning they got gemcitabine-based treatment as a frontline therapy, and then they progressed, and then they went on the trial, okay? And then down here, they had greater than 2 treatments. These were probably patients that had 5-FU-based therapy, probably FOLFIRINOX, then gem-based therapy as second-line metastatic treatment, Gem-Abraxane, and then came on to the trial. So roughly 30% of the patients there. These are the prior therapies, gemcitabine alone or gem combinations, roughly 55%. These were typically Capecitabine, Gemcitabine, and there were Nab-Paclitaxel patients included, but remember the study was done a little before the approval of Nab-Paclitaxel. And then 5-FU-based treatments, roughly 10%, 14% had prior Irinotecan, okay? All right, so very important to understand what patient characteristics, what were the patients that were enrolled in the trial. This is the punchline. Overall survival was improved, roughly a 2-month benefit here. Curves very clearly separate the Nal-IRI regimen, resulting in a hazard ratio of 0.67 and a statistically significant p-value, okay? PFS also was doubled here, 3.1 versus 1.5. Hazard ratio curves very clearly separate. Toxicities. Importantly, we've seen these side effects. So if anybody's used Irinotecan in the past, diarrhea, vomiting, nausea, and then neutropenia, roughly 27%. These are all at the grade 3, grade 4 level, okay? So really nothing new. We've seen all of this in the past. We know how to manage both the early and the late diarrhea that patients experience. Oh, and in terms of quality of life, this was preserved. Looking at global health status, positive in terms of fatigue, negative in terms of physical functioning, but no changes in these other parameters. So one could argue quality of life with this regimen is maintained. All right, so let's go back to Susan, the patient we treated who initially underwent resectable disease. She's found to have T2N1 disease. We give her adjuvant gemcitabine cape based on the SPAC4 data from the UK. She does well, but unfortunately she has recurrence after 3 months. And for those of you that have treated a patient that has undergone a Whipple procedure, yes, their performance is ECOG of 1, but you all are aware that they have nutritional and other conditions, challenges, and so it's very hard for them to, they have to get adjusted, figure out what foods work, how to manage their diabetes if that's present, pain, etc. So very important to consider in the post-operative setting. So Susan had a completed adjuvant chemotherapy. Would it make sense to use a different gem-based regimen or a different 5-FU-based combination, meaning gem, Nab-Paclitaxel, FOLFIRINOX, or the Nal-IRI regimen? So that's one thing that we're going to consider. And then, again, based on when the patient recurred, whether it was 3 months. Remember I said that patients in the NAPOLI trial, if they had progressed within 6 months after receiving gemcitabine in the adjuvant or locally advanced setting, they were eligible to be treated in the trial. And so that's really within 6 months, so 3 months obviously. And again, what I was trying to say about patients having undergone surgery, they're beat up. Are they really going to be able to tolerate an intense regimen like FOLFIRINOX, or is it more appropriate to give them a regimen like the Nal-IRI regimen? And then when we consider recurrence greater than 12 months, do our sequence of treatments, does it change, okay? Especially when we consider the residual toxicities, which I've tried to report to you are neuropathy and thrombocytopenia. You really want a regimen in a second-line setting that does not have these toxicities, and that's why the Nal-IRI regimen is well suited. For example, if you go Gem/Abraxane, neuropathy, and then the Nal-IRI regimen, you avoid some of the neuropathy and the thrombocytopenia. Okay, so that's what I just said. So where are we in 2018? So current approaches in the treatment sequencing. So sequencing, you know, you sequence in colorectal cancer, you sequence in gastric, you sequence in breast, you sequence in kidney, but we never had the opportunity to sequence in pancreas, but now we do, okay? So if you choose a gem-based therapy, gem Nab-Paclitaxel, FDA approved, survival benefit, now you come on to a 5-FU-based therapy, Nal-IRI. Again, FDA approved, survival benefit. So this is a sequence that we're using more and more. Alternatively, if you use a 5-FU-based regimen, FOLFIRINOX, again, the SWOG data presented today is very intriguing. Then you're kind of limited in what gem-based therapies you can select. Again, overlapping toxicities, neuropathy, and thrombocytopenia, okay? So I think we're seeing more and more of the left-sided sequence being used. So who goes on to second-line therapy? So as you guys are aware, not every patient is able to tolerate second-line or go on to second-line therapy. And it's critical. It gets back to what I said in the very beginning. You must manage the patient. You must optimize their performance status. You must sequentially see the patient and care for their pain, care for their nutrition, all of the important aspects of metastatic pancreatic cancer patients. So in the MPACT trial, roughly 40% of patients were able to go on to second-line therapy. I think in the community and academic centers in real world, that number is higher, probably 60%, maybe 70% of patients go on to subsequent therapies. In this trial, 71% of patients went on to 5-FU-based therapies, again, following that sequence. And if we just look right here, the patients had Nab-Paclitaxel and then went on to 5-FU-based therapy. Survival was roughly 13.5 months. People tried to give FOLFIRINOX as second-line therapy. Only 19 patients were able to do that. And their survival was somewhere in the 15.7-month range. So this is just telling you what sequences are available and some of the outcomes that can be achieved. Okay, remember, years ago we were limited to gemcitabine where median survival was only 6 months. All right. Okay, what's in the future with the agents that we have available? What's going on now is this is a planned trial trying to build upon FOLFIRINOX. This is a study, again, with untreated metastatic pancreatic cancer, and they're bringing in the Nal-IRI agent into the FOLFIRINOX regimen, okay? And my understanding is they're still working out the phase 1 dose, the MTD. There's going to be a trial comparing this to Nab-Paclitaxel, Gemcitabine, and also the Nal-IRI regimen. So this is hopefully what we're going to see in the future, and this will hopefully, again, extend survival as we've been doing in first and second line treatments into that 15-month, 16-month, 18-month windows, okay? All right, so summary thoughts in 2018 on the treatment of metastatic pancreatic cancer. Gemcitabine, Nab-Paclitaxel, FOLFIRINOX, and Nal-IRI are all important advances in the treatment of pancreatic cancer. Nal-IRI, as I just showed you, is being tested as possible frontline therapy, and we're able to sequence, something that we were not able to do in the past. We have treatment options. We have to think about how do we sequence our treatments based on outcomes, based on residual side effects, neuropathy, thrombocytopenia, okay? How are we going to sit with the patient at that first visit in the clinic and consider what the treatment strategy will be, first line, second line, okay? Gem, Nab-Paclitaxel, and FOLFIRINOX are both being tested in the locally advanced. There was a poster on that, survival right around 10 months, with Gem, Nab-Paclitaxel being tested in the adjuvant. Hopefully we'll see some of this data coming in late 2018. And then we're also building on these chemotherapy backbones by adding experimental agents. Dr. Hendafar is going to talk about that as well. So with that, I think I'm done. Thank you very much for your attention.
George, thank you very much for that overview. So we have what I'll call an interlude in this program, and I think this is pretty special in terms of, again, hearing the patient voice, and we have some, now these are real patient vignettes. So this is Mark, again, a Let's Win story, who was diagnosed with stage 4 pancreatic cancer in March 2016 with metastases throughout his liver. And so he's recommended to undergo what's called the SINA protocol, which I had to look up also, and that's basically an alternating regimen between a fluoropyrimidine and a Gem-Nab-Paclitaxel base, so it's alternating 8 weeks on and off. That's not the critical point here. But he did very well with this treatment. His CA19-9 declined markedly by more than 2 log-fold, with a significant reduction in his tumor burden. And just here are some of his comments. So he does have some modest, as you might expect, cumulative side effects, including neuropathy, so he is using some adjunctive medicines. But basically, this is now more than a year and a half later where he's continued sort of ongoing chemotherapy. So this raises a question. What do you do with a patient, given that we do have more effective treatments, as George has highlighted? A patient with metastatic disease who reaches a plateau in response or experiences cumulative dose-limiting toxicity. So do you continue on that treatment sort of indefinitely, maybe with modifications in dose and intervals? Do you, at that point, if they were on Gem-Nab-Paclitaxel, do you switch them to a non-cross-resistant, a fluoropyrimidine-based regimen? Do you use some form of quote-unquote maintenance therapy? For example, if a patient was on FOLFIRINOX, do you simplify to infusion of 5-FU or maybe Capecitabine? Or you recommend a complete chemotherapy holiday? Time permitting towards the end, maybe we'll have a little give and take, and I'll ask our panel to discuss, because I think it's becoming an increasing scenario that we face in our practice of what to do. So I think this is very interesting to see that there's a pretty even split between all of these options. Sort of a nice problem to have. Okay, a second patient, this is Rachel, diagnosed with stage 4 pancreatic cancer, really describes sort of the paralyzing feeling associated with this diagnosis, as you can imagine, especially for someone so young who previously had a very healthy lifestyle. So her oncologist recommended that she start on FOLFIRINOX, but she instead decided to explore other trial options. In fact, went on what was called the HALO 202 trial. You'll hear more from Dr. Hendafar about this. This is evaluating a stromal depleting agent called PEG-PH20 in combination with gemcitabine Nab-Paclitaxel. And this was back in 2015. And in fact, more than 2 years later, she remains on study with an excellent response. Again, the similar question I posed before applies in this setting too, but she's remained on treatment now for more than 2 years. But this is more a question in terms of why you may choose not to refer a patient, or what hampers you from perhaps referring or enrolling patient on a clinical trial with metastatic pancreas cancer. We know the rates of accrual to pancreatic cancer trials is still well under 10%, so not hitting sort of the target that we would like in terms of trying to get most or all of our patients on studies. But is it because you don't have any available trials at your site or nearby? Is it because your patient may not meet eligibility criteria? Maybe it's performance status, maybe it's hepatic or hematologic parameters. Is it that you've offered, but the patient or his or her family are not interested? Or is it because you personally have a feeling that our current state in pancreas cancer is not great and you're skeptical of the experimental therapies? Most folks choose one or two, which is basically a lack of available trials, and that certainly is relevant depending on where you practice, or the patient does not meet eligibility criteria. And for those of us who develop or think a lot about clinical trial design, this is certainly a main point in terms of what eligibility criteria can we really, are we perhaps too traditionally wed to? What can we potentially liberalize to allow more patients to participate? Should we have studies specifically for the elderly, for the poor performance status patients, certain subgroups that perhaps historically we've avoided? So this is certainly relevant, so thank you for weighing in here. Third and final patient voice from Let's Win is a gentleman named Steve, originally diagnosed with stage 2B pancreatic cancer. And again, I don't mean to rush through this. The quote here is for you to maybe dwell on a little bit, just to absorb the patient experience of someone, especially with the internet available to them and the statistics they read, and certainly how sobering this diagnosis must be. But Steve underwent a Whipple procedure and got chemotherapy afterwards, but unfortunately subsequently developed liver metastases. He received FOLFIRINOX with good response, but he, in addition, and I think perhaps as an increasing number of our patients are doing, requested molecular testing. And this showed that he actually had a BRCA2 mutation, both germline and in his tumor. And so he then enrolled on a study evaluating a PARP inhibitor, which again, you'll hear a little bit more about from Dr. Hendafar. And he's demonstrated favorable response and continues on therapy today. And so this gets to my last question, and that's how often do you perform molecular testing? So let's make this a question specifically testing of the tumor sample. So not genetic counseling, not germline testing, but actual testing on the patient's tumor sample. So is it pretty infrequently, less than 10%, maybe 10 to 25% of the time, 25 to 50%, or greater than 50% of the time? And that might be from any number of multi-gene panels commercially available or whatnot, but just let's just say some multi-gene panel or next-gen sequencing profiling. Okay, good. So it really, this reflects just a wide distribution of our practice patterns here, and I think that's a really nice reflection of where we're at today. And I made this the last question because I think it segues really nicely into our next speaker's talk, Dr. Hendafar, who is going to talk about some novel therapies as well as the use of what I'll call precision oncology in his practice, as well as some data in terms of supporting this as an option that we should be thinking about a bit more. So I'll turn this over to Dr. Hendafar, who's going to talk about new frontiers, novel agents, and combinations across pancreatic cancer. Andrew?
I'd like to thank the organizing committee, Dr. Koh, Peerview, and Lustgarten for allowing me to, or inviting me here tonight. So today I'm going to discuss novel therapeutic approaches to pancreatic cancer. And for the purposes of this talk, I've divided it into 3 categories. 1, stromal targeting. 2, precision medicine. And the third, and most popular, immuno-oncology. The pancreatic tumor microenvironment is complex and dynamic. There are several targets, including the ductal epithelial cells, macrophages, mast cells, fibroblasts, myeloid-derived suppressor cells. And the biologic features of pancreatic cancer are quite unique. There's an abundance of extracellular matrix that is hypothesized to create a barrier to drug delivery by compressing the blood vessels. There's low vessel density and hypoxia, and there's cancer-associated fibroblasts and inflammation, which actually dampens the immune system. Now, my personal research interests really surround metabolic reprogramming and weight loss in pancreatic cancer, and this is particularly associated with KRAS alterations. Unfortunately, treatments in this area are not yet ready for prime time. So let's discuss stromal modifying agents. We have lots of targets to choose from, and let's pick the ones that are the most advanced in development. We have pegylated recombinant hyaluronidase, PEG-PH20, vitamin D analogs, and Bruton kinase inhibitors, or Bruton tyrosine kinase inhibitors, which haven't been discussed much recently. So hyaluronin is a naturally occurring, linear, megadalton polysaccharide and a major component of pancreas cancer stroma. HA accumulation in preclinical models actually compresses the tumor vasculature as hypothesized to reduce the ability of chemotherapy to kill the cancer cells. And importantly, HA accumulation is associated with poor prognosis in pancreatic cancer. Here's a nice cartoon demonstrating the hyaluronin in the microenvironment. Here you also see the macrophages, the T cells, Tregs, the other regulatory cells, and fibroblasts. When you see the hyaluronin depleted in this red cartoon here, these red squiggles, here you see two things happen. One, the blood vessels are decompressed. They look nicer, better delivery. You also see more immune cells in the tumor environment. The HALO 202 study was a large randomized phase 2 study. In March of 2013, it began. Patients were randomized 1-to-1 to chemotherapy with Gem/Abraxane versus pegylated hyaluronidase and Gem/Abraxane. After the first 146 patients were enrolled, there was a temporary clinical hold because we noted that there were many thromboembolic events in the pegylated hyaluronidase arm. The hold was then lifted after the introduction of low molecular weight heparin as a prophylaxis. The first 146 patients, the HA levels were analyzed and a diagnostic assay scoring algorithm was developed. In stage 2, this algorithm was prospectively validated. In August of 2014, enrollment continued or recontinued, and the study was completed in December of 2016. At that time, the study was found to have met the primary endpoint. The progression-free survival in the experimental arm with pegylated hyaluronidase was 6 months, compared to 5.3 months in the chemotherapy alone arm. This was statistically and clinically significant. Thromboembolic events, which were a concern in the study, were well controlled with low molecular weight heparin. In stage 2, the first dose of low molecular weight heparin was 40 milligrams per day. This improved the thromboembolic rate, but still not quite acceptable in either arm, actually. It was a high event rate. When it was increased to 1 milligram per kilogram per day, which is commonly used in European nations, the thromboembolic rate was acceptable and equal across both arms. And the very interesting part of the study was that when we reviewed the HA high arm, about 50% of the patients, we noted that the progression-free survival was enhanced. So it was 9.2 months in HA high patients versus 5.2 months. And because of these provocative findings, a phase 3 study was commenced. This is 420 patients are to be enrolled, randomized in a 2-to-1 fashion between PEG-PH20 and chemo versus chemo and placebo. The primary endpoint is going to be progression-free survival with a hazard ratio of 0.59, which I think is a healthy hazard ratio for this type of study. The study was initiated in March 2016. It's accruing well and almost halfway complete. Earlier today, we had results from a study from SWOG, the 1313 study. In this study, patients were randomized between FOLFIRINOX as the standard of care arm, and Dr. Kim alluded to the nice results of that arm, plus or minus PEG-PH20. The design of the study was quite different. The delivery of the pegylated hyaluronidase was also different, And today the results were reported that the survival and outcomes were not as expected. The study was terminated early and not continued. So let's talk about another interesting stromal agent that's widely popular in the community, and that's vitamin D. For obvious reasons, it's called the sunshine vitamin. How can you not like vitamin D? So the vitamin D receptor, though, you might not know, is expressed in stroma from human pancreatic cancer. We also know that calcipotriol, or vitamin D, reduces fibrosis and inflammation in preclinical models. And how it works is quite interesting. I'm not sure if you've heard of the pancreatic stellate cell, but this is the cell that everybody thinks is the bad actor in pancreas cancer. It releases the extracellular matrix, produces cytokines and growth factors that promote tumorigenesis and a bad environment for healing. In these preclinical models, when we give vitamin D analogs, it makes the pancreatic stellate cell quiescent and more amenable to treatment. Because of these promising preclinical findings, there are several clinical trials available and grants that have been awarded, specifically by Lustgarten actually, for this treatment. There are currently 5 active clinical trials for vitamin D analogs. 3 of them are recruiting, and 2 out of those 3 are adding a checkpoint inhibitor with the vitamin D analog. Again, the idea being the stroma, within the stroma, we have immune cells also that we can utilize in addition to making the environment more favorable. Another very interesting compound that is re-engineering the stroma is Bruton tyrosine kinase inhibition. Again, preclinical models are very impressive. When you add ibrutinib to gemcitabine, you see increased tumor kill, you see increased T cells being delivered to the microenvironment, and you even see re-engineering of the stroma with less desmoplasia. Because of these very promising early preclinical findings, a randomized large phase 3 study was conducted and completed rather quickly. In the RESOLVE study, 420 patients were randomized between Abraxane and gemcitabine and Abraxane versus ibrutinib, gemcitabine, and Abraxane. The inclusion criteria, standard phase 3 first-line clinical trial, except in this trial, all the patients had to have been untreated. So patients who recurred in the adjuvant setting did not qualify. I'm actually very personally interested in seeing the results of this study. They're soon to be available, so my fingers are crossed on this one. Now I'm going to talk about precision medicine. And Know Your Tumor is an interesting program which comes to mind when I think about precision medicine, and I'll explain this in more detail soon. But precision medicine is about knowing your tumor. And when we talk about precision medicine, the definition is that drugs that target pathways, processes, and physiology that are uniquely disrupted in cancer cells, whether we're targeting receptors, genes, angiogenesis, stromal alterations, metabolic derangements. But when I really think of targeted therapy, I'm thinking of personalized therapy. I'm thinking about a patient coming into the clinic and getting a therapy specifically for him or her based on his or her tumor. Now, what we know about pancreatic cancer, we've learned through the years and through the Genomic Cancer Atlas and other sequencing studies that the majority of the alterations are KRAS, P53, SMAD4, and CDKN2A. However, if you look around, you'll see a lot of other alterations, a lot of other things happening. So let's keep that in mind. When we use genomic analysis as well, we get a different perspective on the tumor. Whereas in the clinic, we see a wide variety of presentations and outcomes. When we start to dig a little bit deeper, we start to form groups. For example, in this important paper by Bailey et al. In Nature, we see the identification of 4 molecular subtypes in pancreatic cancer. We see a squamous, we see pancreatic progenitor, immunogenic, exocrine, endocrine. And when we look at what types of patients are in each subgroup, we start to see, well, the squamous, obviously, they're in the group, adenosquamous here, their prognosis is a little bit poor. But here we have a classical group, and their outcomes are actually much better. And in a poster, I don't know if you're able to see it today, we had a different group who also divided patients into a basal-like or a classical-like with differing prognosis and outcomes. I think it's quite important to keep in mind. And hopefully, it kind of paves the way for new approaches in this disease. One of the targets that has been heavily researched is BRCA. We've already talked about it tonight. And this study is a phase 2 study with rucaparib. It's one of my favorite studies because they included germline and somatic BRCA alterations, which of course is very important and very favorable for the patients because it includes more patients. We know about 5% of pancreas cancer is BRCA-associated germline, but an additional about 5% is somatic. In this group of 19 patients, there, as you can see, there are several patients that received benefit from just an oral pill that was incredibly well tolerated. And I remember a lot of these patients, and they did really well. Unfortunately, the response rate did not meet a criteria for continuation. However, other efforts in the germline BRCA mutation population includes olaparib. In this phase 2 study, 23 patients were given olaparib. These patients had already progressed, most of them through 2 lines of therapy. And in 3rd-line treatment with just an oral agent, there was a 22% response rate, which is very favorable in this patient population and quite promising. Because of this data, the POLO study was initiated. This is a phase 3 randomized study of PARP inhibition as maintenance therapy. So patients receive 16 weeks of platinum-based chemotherapy, and if they have a germline BRCA mutation, they're randomized between PARP inhibitor or placebo. Here's a nice picture of the study design. If they receive olaparib or placebo and they progress, then they return to the systemic therapy that they received prior. Now, what's interesting about this study is if you enroll a patient, even if they don't have BRCA testing done, the study will take care of the BRCA testing for them. So I think if the study is available and open anywhere nearby, it's imperative that we refer patients to, at least they can get screening, which is included in the study. Now, there are also many other efforts looking at PARP inhibitors, some of them combining them with chemotherapy. At our institution, we are very interested in combining PARP inhibition with radiation therapy, and we have found definitely improvements in outcomes, specifically in patients with BRCA alterations and other DNA repair deficiency types. Now, through the process of introducing personalized medicine into pancreatic cancer, we've made some interesting observations. Here is a case series of pancreas ductal adenocarcinoma patients with ALK rearrangements. And what's really interesting about this case series is, one, the age of presentation. These patients are, all of them, between 32 and 46 years of age. None of them have a KRAS mutation. And these tumors actually respond to ALK inhibitors. So here we have a very interesting case. Here's a 34-year-old orthopedic surgeon who, probably 1 month out of fellowship, in the operating room, feels a little faint. He has to come out. He gets checked up. His hemoglobin's 6, so he's very anemic. And we find that he has a pancreatic tumor invading into his intestine, causing bleeding. Immediately, we say, you need to get on FOLFIRINOX. He enrolls in a Know Your Tumor program, which is a precision genomics program provided by PanCan. He gets sequenced, he gets molecular profiling. After 6 weeks of therapy, we restage him here. And it might be hard to see, but this is actually worse. So after 6 weeks of intense chemotherapy, his tumor has grown. He has a new duodenal stent. He has a new J tube that's for feeding. He's doing really poorly. And all the smart people that I know, I talked to about this ALK rearrangement, they said, put him on an ALK inhibitor right away. That's what you have to do, no question about it. And before we'd done the sequencing, I wouldn't even have thought about that this would possibly be an option. So he went on the ALK inhibitor, he went on chemoradiation, he responded, and he responded some more. And then we had a gentleman who went from an unresectable, locally advanced tumor to a pancreas resection. He had a pancreatic duodenectomy, margin negative resection, and he's still on crizotinib and still doing quite well. Actually, I got a text from him today telling me that he had the flu. So I had to call in Tamiflu, if you can believe it. If you can believe it. That's the only call I've had from him in about 6 months, if you can believe it. It's remarkable. So what is this exploration to precision medicine for pancreas cancer? Also, what have we found? Well, I personally believe that a lot of our efforts should be focused on the KRAS wild-type group. I could be wrong, but that's what I'm thinking. And there was a great report today looking at 3,500 patients that were sequenced through Foundation Medicine, that 390 of them were KRAS wild-type. That's 11%. If you would have asked people before this report, most people would have guessed about 5%. And many scientists and investigators believe that this KRAS wild-type group is growing. And what's also astonishing is that 41% of these patients had a BRCA gene alteration, which I don't believe. I almost want to look through all 1,400 just to see if that's really right. That seems really high. 0.6% were MSI high, which was unfortunately lower than we would have hoped, but what we expected. And what we found really interesting, in the KRAS wild-type cases, we found 68 patients, or 17%, had alterations in the RAS-RAF-MEK pathway. In the Know Your Tumor experience, we looked through 750 patients. We found 25 patients with pancreatic ductal adenocarcinoma and BRAF alterations. We found BRAF V600E mutations. We found these in-frame deletions. Now, if you talk to anybody who knows about BRAF, they get really excited about these in-frame deletions. They really do. These are very novel. 24% had BRAF translocations, and an additional quarter had non-canonical BRAF alterations. And we have anecdotal cases of patients with BRAF V600E responding to therapy, and we also have cases of in-frame deletions responding to MEK inhibitors, and we have BRAF translocations also responding to MEK inhibition. So this is actually rather interesting, and it probably deserves more research. Now, what is the Know Your Tumor program? So this is an effort sponsored by PanCan, where patients can get personalized medicine, and physicians can refer their patients quite easily. They contact the PanCan phone number. The consent process is done. The physician doesn't have to drive the process. Once the patient consents for the procedures, the records are sent to PerThera, or Personalized Cancer Therapy. The testing is sent out and performed at several laboratories. The data comes back to an expert medical review panel. A personalized cancer therapy report is developed, and this report is sent to the physician and to the patient. And this has been very helpful in promoting this process, and I think we've learned quite a bit. So finally, we'll talk about immuno-oncology. Immuno-oncology has really changed the way we're treating cancers. And unfortunately, those of us who treat GI cancers, we sometimes feel a little bit left out, although thank goodness there's new data in HCC and gastric cancer. But in pancreas cancer, immunotherapy has not been very effective. And that's for two reasons. One, there's very limited number of infiltrating T cells in tumor specimens. The other issue is the mutational burden of these tumors is very low, and the rate of microsatellite instability is also very low. Now, there have been several studies looking at immune checkpoint inhibitors. Single-agent PD-1 and PD-L1 has very minimal activity. CTLA-4 monoclonal antibodies activity is not very high either. And now most of the efforts are focused on combining chemo with checkpoint inhibitors, and also combining checkpoint inhibitors in addition to chemotherapy. Vaccine therapies have unfortunately not worked in the recent studies. CRS-207, GVAX, the hyperacute vaccine, those programs, from my understanding, are closed. Now, one bright spot has been using checkpoint inhibition in patients who have microsatellite unstable tumors. Now, you see here in a plethora of GI tumors with microsatellite instability, single-agent pembrolizumab is quite effective. So you didn't have to go to the other talk next door to hear this. And there are several pancreas cancer patients in this series that derive benefit. So this is definitely an effective therapy and option for these patients. And IDO is also a very interesting target. So IDO is a tryptophan catabolizing enzyme that plays a role in normal regulation and peripheral immune tolerance. So IDO facilitates evasion of immune-mediated destruction. So of course, it makes sense to use IDO in pancreatic cancer. And also there have been several studies looking at the combination of chemotherapy in addition to IDO, and those are ongoing. And there have been results of previous studies that look promising. One interesting combination immune therapy approach has been cabrolizumab in combination with nivolumab. So tumor-associated macrophages inhibit anti-tumor T-cell activity. So here's a TAM, it's a bad player. It kind of inhibits this T-cell here. In pancreas and other cancers, high level of tumor-associated macrophages are associated with a poor prognosis. And the signaling is done through the CSF1 pathway, which promotes the maintenance and function of these TAMs or TAMs. So cabrolizumab is a humanized IgG4 monoclonal antibody that binds the CSF1R receptor and depletes the tumor-associated macrophages. This restores T-cell function and anti-tumor response in preclinical models. So in a large phase 1-2 study, 31 patients who are refractory to chemotherapy were treated with the cabrolizumab and nivolumab combination. And of 31 patients, 5 had a response, as observed by their clinician. Of these, I would say 4 of them were confirmed. And what was interesting was that several of these had a prolonged duration of response, which for pancreas cancer patients is great. The rate of response is not that high, but again, in this disease, it's still interesting and probably warrants more evaluation. So final thoughts. Despite historic challenges in developing targeted therapeutics for PDAC, several new approaches are being rapidly developed in clinical trials. These include stromal agents, Bruton tyrosine kinase inhibitors, and PARP inhibitors. Immune therapies hopefully will have a large role as well, but these need to be further developed. I hope I've given you some insight into new approaches to pancreatic cancer, and thank you for your attention.
Thanks so much, Andrew. So I'd like to now use the last 10 minutes of our session to look at some of the questions that the folks in the audience have posed. I want to be sensitive to everyone's time, so we will stop at 8:30, so I apologize if we don't get to everything, but I'm going to pose some of these great questions to our panel. First one is, I guess, George, after all the data you presented about nanoliposomal irinotecan, someone asks a very reasonable question. Is it still reasonable to offer FOLFOX second line after progressing on a gemcitabine-based regimen?
So, again, Abraxane, Nab-Paclitaxel, Oxaliplatin, there are toxicities that you carry over. So neuropathy, thrombocytopenia, and I mean, we have an approved drug with a survival benefit with the Nal-IRI regimen. So is it still appropriate? I think you really have to argue that what we're seeing more and more is incorporation of Nal-IRI in the second line. And I think the data with Oxaliplatin in the second line is controversial. So if you're going to follow Category 1 recommendations by the NCCN and by ASCO, I really think you do have to stick to Nab-Paclitaxel and then the Nal-IRI regimen and kind of push Oxaliplatin, or a platin rather, maybe into third line. So nothing is absolute though.
Yeah, a lot of these patients, I think, as we're changing the natural history of this disease, are going through 2 or even 3 lines of therapy. Yeah. So whether switching to FOLFOX second and then going to a Nal-IRI third line or vice versa, I don't think we know the answer to that. George pointed out some really mixed data as far as that goes. A lot of my colleagues are even just going with FOLFIRI, and I think it's important to emphasize that we just don't know. There's not enough evidence in terms of using free irinotecan as in FOLFIRI and assuming that's as good as nanoliposomal irinotecan. So I think we need to be cautious in terms of what we extrapolate. Kind of along the same lines, someone asked, well, is there any experience using the nanoliposomal irinotecan with capecitabine instead of infusional 5-FU? Go ahead.
I mean, I think that's being evaluated, but that's not the way the trial was done. So I'd be cautious. There is the Nal-IRI regimen, which is out there, which causes a lot of diarrhea, a lot of side effects for patients in colorectal cancer. So I would be cautious with using that. And Andrew has heard me enough talk about pancreatic cancer. Capecitabine, you have to be careful. A lot of these patients are on proton pump inhibitors. There's data in colorectal that suggests that survival can be significantly altered worse when patients are on capecitabine and a PPI, proton pump inhibitor, because of absorption of the capecitabine. So be cautious using capecitabine, both in the adjuvant and the metastatic setting. And right now, the answer to this question is we don't have data on using capecitabine and Nal-IRI.
Okay, and then a question of, well, why not use Nal-IRI in FOLFIRINOX instead of the free irinotecan? I think George showed one slide highlighting an ongoing trial. We don't have the dosing yet of Nal-IRI incorporated into the FOLFIRINOX regimen. So I think to do so would be a little bit premature and with some uncertainty in terms of appropriate dosing. I think that's best left to see what the trial data are in the randomized phase 2 study of that combination in the frontline setting. Let me turn to Dr. Hendafar because there's some BRCA-related questions. First is BRCA testing something you personally consider in all your pancreatic cancer patients?
That's a great question. So I work in Los Angeles at Cedars-Sinai Hospital, and as you can imagine from the name, we have a population that's selected for Ashkenazi Jewish families. So we do look for BRCA alterations more than maybe at other hospitals or more other areas. I would say that unfortunately, unless you have a family history, it might be difficult to have germline testing done and have it be reimbursed by insurance. So that's one issue that comes up. I mean, if we could, I think we would screen the majority of patients who present at a younger age than would be expected or have a family history that's concerning. And so any patients that meet those kinds of criteria, we do send for genetic counseling and to consider it. Because of course, BRCA alterations are not just important in your patient, but in the patient's family, they're incredibly important, right? Especially if they're germline. And if you can identify a BRCA2, which is sometimes not so easy to find in a family, you've done a lot of people a really nice service and helped a lot of people out in the family. So those are really important.
So along the BRCA lines, again, there's germline BRCA, there's somatic BRCA, there is BRCA-ness, and perhaps other genes relevant in homologous repair deficiency, ATM, RAD51. So there are others, and so I guess the question is there any difference in, sort of there's data that in terms of responsiveness to platinum analogs in that context, but do you think there are a subset of patients who sort of fit that more BRCA-ness profile? What proportion of patients, and do you think they are truly more susceptible to platinum agents, and how would it influence your treatment decision?
Yeah, that's a great question. So I would say you can put them in different tiers of BRCA-ness. I would say tier 1 are germline BRCA alterations that you know are relevant because the patient has the germline mutation and has the cancer. There's no question those patients should receive platinum-based chemotherapy. Then you have probably, and those I would also include PALB2 if they have a germline, and even ATM if they have a significant germline ATM. I think you have to take those very seriously, and it does suggest that genotype is important to the patient's care. Now there's tier 2 alterations where you can't say for sure, but if they exist, for example, somatic BRCA, somatic ATM, And there are other, types of genes like Fanconi anemia genes that are suspected to be involved. These other tier, it would suggest that you might want to use a DNA repair damaging agent, but not necessarily. So I think you have to use your own clinical judgment, and hopefully with more time, we'll have a better understanding of what we should do in every clinical scenario.
Okay, there are questions relating to stromal depletion strategies and specifically PEG-PH20. Are either of you assessing HA, the hyaluronic acid, in your patients? So I guess that must mean outside the context of a clinical trial.
The drug is not commercially available, so I'm not using that as a marker for predicting whether patients will respond to stromal agents such as, Nal-IRI or Nab-Paclitaxel. So I think the answer to that is not ready for prime time.
Right. So yeah, the HA diagnostic assay is proprietary from Ventana. It's not even commercially available. So you wouldn't even be able to do it outside of a clinical trial.
Yes, so that is the correct situation as it stands right now. On the estimated proportion of HA high patients for the current HALO study based on HALO 202, the phase 2, is estimated to be somewhere in the 30 to 40% range, meet that qualification of being HA high. I don't know if you know the answer to this. In the HALO 202 study, were there any other features besides the HA high that predicted for responsiveness to treatment on that study?
Not that I'm aware of.
I don't think that's been, so this has been published in the Journal of Clinical Oncology, and nothing specific in terms of standout. A couple other maybe practical questions. One is, anyone use GTX frontline? That has been on the NCCN guidelines as sort of a category 2B. The answer is that there is no level 1 evidence for that. The small amounts of data coming out of Columbia and other places suggest some promise. It probably is a reasonable response, but I think now that we have level 1 evidence for the regimens that George highlighted, we just don't have that same level of evidence for GTX. And then someone asks, any role for erlotinib in second or third line therapy? Anyone here still using erlotinib in any context?
Yeah, I mean, I just want to caution people. I've seen erlotinib used as monotherapy. That's really pushing it there. So yeah, I'd probably put erlotinib in a drawer and call it a day.
Yeah. I mean, there was some provocative data that maybe in the KRAS wild type population it would have, but that doesn't even make a lot of sense. So I agree. For the most part, we don't use it or prescribe it.
Yeah, I think myself and I think most of us who have sort of moved on from erlotinib. Final question, I think it's good, it's more from a research realm. In terms of the choice of chemotherapy platform, what are the natural combination partners for agents like PEG-PH20 or PARP inhibitors, and should they be validated? Some of that are purely pragmatic decisions. It is challenging, as was highlighted in the SWOG 1313 study, in terms of using FOLFIRINOX as a backbone. Certainly, trials on a path toward registration, having the reference arm being gemcitabine Nab-Paclitaxel argues that the study arm is Gem-Nab-Paclitaxel plus drug X. I don't think that always necessarily has to be the case, and certainly we'd love to have a stronger biologic or mechanistic rationale why certain agents might play better with one particular chemotherapy backbone than another. And I think the very sobering data we heard today with FOLFIRINOX with the PEG-PH20 highlights the fact that whether it's from a mechanistic standpoint, whether it's from intolerable toxicity, that the chemotherapy backbone very well may matter. And I think it behooves us, for those of us who are trying to think about and design clinical trials, to keep that in mind. Thank you very, very much. I hope you all have a good evening.
Thank you for listening. Download materials and complete the post-test for instant credit at www.peerview.com/NMJ. This activity is supported by independent educational grants from AstraZeneca, Halozyme Therapeutics, and Ipsen Biopharmaceuticals Incorporated. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.